George Crawford, nice to meet everybody. Yes, ma'am. I'll put it on mute. So, COVID, we'll just jump right into it. Realistically, that dominates anything that we talk about in medicine these days. You're looking at about 27 million cases in the United States. Of those, about 500,000 have died. If we're looking at Alabama, we're looking at about 500,000 cases here, with a much smaller death rate, around 27,000. What that means is, one, that the United States counts for 1/4 of the number of COVID cases in the world, although we only make up 7% of the population. So, and there's a lot of issues with that: land size, population density. There are a host of reasons. But in Alabama, the reason that we're getting hit pretty hard is realistically one thing and one thing only: access to care. We always want to be better than Mississippi. Sorry for anybody here, but we've always kind of been at the bottom for education. We've been at the bottom for healthcare. We've been at the bottom for a host of things. And when you have something like COVID, it just shines a light on those issues. So these are all problems that we hopefully can get addressed after COVID, but we also probably should have paid a little more attention to before. But again, nobody knew it was going to bite us in the butt. Case in point is at RMC, we have about 385 beds at regional. At Stringfellow Memorial Hospital, we have about 88 to 100 beds. So we have 500 beds almost between both facilities. But that's not what causes us to get full or get overcrowded during COVID. It's nursing. We have a nursing shortage. No matter how many beds I have, if I don't have enough nurses to take care of those patients, I then run into a situation where I can't take care of people. Is that something that we as a hospital have failed? Yes, we should have done a better job with that down the line. But again, there's a host of issues. And that's one thing that you will see going forward from a American healthcare COVID standpoint, is that we will start having to focus on these problems that have been shown to us because of COVID in a different way, whether that's structuring nursing contracts differently, whether we have to start paying nurses more in this area, whether it's changing the way that Blue Cross Blue Shield, Medicare, Medicaid cover certain disease processes, the way that they pay hospitals. So all those changes are coming. But right now, a lot of what is happening in the United States from a medical care standpoint is really just us figuring it out. I mean, when we came out, it was just like the flu. Not quite like the flu. We're going to get a vaccine in 3 months. It's going to take 18 months. Actually, it only took 9. Is this vaccine different? Yes. Have we ever used it before? Smaller diseases? Yes. So healthcare is behind, not so much because we're behind, but it's just because this is something new. Look at it from a overall standpoint of viruses. When HIV came on, or AIDS came on the scene, it took us about 4 years to actually come up with treatments. It took us about 1.5 years to even understand how it was transmitted. It took us about another year to figure out that it wasn't just one treatment, and it was not something that we could vaccinate against. It was something that we needed to treat symptomatically with medications and boost the immune system. So, we've kind of been in a rush from last year to now figuring this out, coming up with a vaccine. And then 2021 rolls around and we got variants now. We have different variants that may or may not be responsive to the vaccine, but we also have different vaccines. I think we were talking about it early. Initially, we had Moderna and Pfizer, BioNTech. Those 2 vaccines come out. But over the next couple of months, we'll see 2 more probably coming down the pipeline. Johnson & Johnson has one that's about 85% effective with 1 dose. And they're probably both similar. It's just the way that they were tested. We have another one coming out, but the AstraZeneca trial, their vaccine that was originally thought to be a very good option, is not doing well against the variants in South Africa. So that one may not be an option depending on what variants we have here. And we're still plagued by the same things that we had before. Testing. We're not doing enough testing. Our tests in the beginning were not accurate. So sometimes we have false negatives, sometimes we have false positives. And again, Access. If you live in a state like Mississippi, I'm gonna keep picking on them because that's actually where my family's from, so got a little credit, I can do that. If you're in a state where you don't have access to care, to believe that you're doing a good job of testing and the actual incidence of the virus is not reasonable. So, we always tell everybody, the incidence is 1 in 22 or 1 in 30. But remember, in this state, because we have a healthcare issue, those numbers are probably a lot higher. I saw an article a couple of days ago, and actually I think 3340 ran the story about Alabama being one of the least safe states in the United States, and that's partially because of our access issue. And access is not just coming to the doctor, it's getting to a place where you can get tested, getting to a place where you can get vaccinated, getting to a hospital in time if you are sick. So all of those issues play into COVID, and we got to address them. And again, that's going to take some time. It's going to take time, not because we don't know what we're doing. It's taking time because this is new, and we're figuring this out as we go. So there will always be a situation where the information changes. We just kind of stay on top of it and do the best we can. And another thing that's kind of on the back burner that we don't talk about with COVID is colonoscopy, screening colonoscopies, screening mammograms. You're starting to see a decline in the number of women getting mammograms, people keeping up with their colonoscopies because of COVID. I don't want to go to the doctor. I don't want to go to the hospital. Most of your healthcare professionals have now not so much switched to telemedicine, but at least have a telemedicine option. So those are things that if you call your primary doctor and say, hey, I need to get my colonoscopy, I hadn't had it in 5 years, 10 years, at the age of 45, if you have a family risk, 50 if you don't, can I get that set up? Most times they'll say, okay, yeah, we'll do a telemedicine, and then you only have to see them when you're getting that done. Mammogram, same thing. A lot of physicians have transitioned from coming in, getting a self-breast exam. It's kind of questionable anyway, to just go ahead and ordering the mammogram, getting that baseline done, and then follow up once a year. So don't let those other things, those maintenance things that you have, fall through the cracks because of COVID. And that's pretty much the sum up, because I know everybody's got 1,000 questions. So if y'all want to just jump right into the questions, or we can talk about the vaccine processes going on now. I think today and tomorrow in Oxford, Wednesday. Yes, ma'am.
Since people are going to haven't had the vaccine yet.
Okay.
I got 2 different types of information. One was for to drink Pedialyte and stay hydrated.
Okay.
And take Tylenol.
Okay.
The day that you get your vaccine.
Okay. So
and now Dr. Fauci came on and said no Tylenol.
Right. So okay. So let's back up and go with the flu vaccine, okay? So with the normal flu vaccine, what we normally would say was take antihistamine and maybe Tylenol if you have a fever or chill. So the reason that this is a little different, because it's a messenger RNA vaccine, it is truly just a piece of the protein that allows the COVID virus to enter the cell and then replicate. So we're not giving pieces of the virus. It's just, it's not the virus, it's really just a piece of it. So with that piece, what you want your body to do is get an immune response to it. So it says, okay, this is foreign. I don't like this. Get it out. Once you start giving people antihistamines, once you start giving people Tylenol, what they're seeing is your immune response is not as robust. So as opposed to saying, get the heck out of here, it's like, I don't really like this that much. So what they're worried about is that you're not going to have that same efficacy of 94% with Moderna, 95% with Pfizer, 85% with Johnson & Johnson if you start giving things like Tylenol, if you start taking Benadryl before. Now, Dr. Fauci's point is based on one thing and one thing alone. When we do a research study, you come in and you say, okay, what medicine are you on? X. What do you do? X. What do you do? Y, Z. So they ask you 1,000 questions. If they see where 5 out of the 100 people that actually contracted COVID and got sick during that trial were on Tylenol. Is it the Tylenol, or is it the fact that just those 5 people were on it? Because we're not exposed to that actual data, it's hard for us to answer that question. Now, he does have access to the data, and he's looking at it, and he's probably saying, okay, this is a trend that I'm starting to see now that we've opened it up from 30,000 to 300,000 to 30 million. So they're really watching those numbers, and you'll see stuff comes out. But remember, that's based on that initial trial. You know, and originally everybody was talking about with the vaccine, hey, I might get Bell's palsy. The Bell's palsy in that population that took the vaccine was the exact same as Bell's palsy in the general population. So that's why that stuff comes up. People look at a little bit of data and extrapolate it. So if it were me, what I did was I just got the vaccine and just let it ride. You know, I just let my immune system do what it does, because at the end of the day, I think that's the safest. It's not the most comfortable way for me, but I think it provides me with the most protection. So that's what I went with. Yes, sir.
2 questions.
Go ahead.
One, off of the vaccine, but talking about treatment.
Okay.
In Israel, they had something like a Tamiflu for COVID.
Yes.
That they're giving.
Yes.
Do you think something like that will be available long-term here?
No.
And the second thing is, are these vaccines that we're getting going to be yearly like the flu vaccines in your estimation?
Okay. So the first answer is no. Second answer is I don't know. And we don't know, because remember, we're looking at something that happened January 2020 to January 2021 so far. So we haven't had a year of people having COVID. What we do know is that your immune response to COVID, when you get it, you know, you're out hanging out with your kids, whatever, get COVID, we know that usually lasts about 3 months. We know that after 90 days, you are probably susceptible to another variant, and that's called a reinfection. If you look at the vaccine, initially when it came out, we were like, okay, you got 6 months. We've now extended that to 8 months. Because remember, those 33,000 people that they have, we're still following them. So they're still doing titers, they're still asking, have you know, you're out hanging out doing what you need to, did you catch COVID again? So a lot of that data is forthcoming. If you ask me to take a guess, I would say it probably will be something that we have to do once a year. I do not think it'll be permanent, but I don't think it'll be less than 6 months. I think it'll be close to about a year. So once a year, you'll have to get it. Yes, sir.
What you started with, talking about nurses, I guess, a two-part question. How do we, being someone who worked with you, how do we kind of change the idea of the stigma that only women are nurses?
Okay.
Certainly at a young age, if you say
Right.
to a young boy, would you like to be a nurse someday, he'll back up and kind of look at you.
Right.
And then, do we see perhaps such a shortage in nursing due to the behavior of doctors? Because I've witnessed relationships between nurses and doctors, and you feel so much better when your nurse is in the room versus sometimes when your doctor's in the room.
Right.
And you kind of see the differences as to how they relate to people. So how do we do a better job of letting people know nurses and school teachers are the greatest people in the world?
So, you know, I think a lot of that is going, hold on, let me make sure the CEO of the hospital is not on here before I get in trouble. Does anybody work for Blue Cross Blue Shield?
Oh, what do you mean, work with them?
Work for them?
No.
Okay, all right, good. Okay, all right. So some of that will change just because of the nature of social media right now. I think a lot of times, especially the younger generation, that's where they turn to. And if you look at a lot of Instagram, TikTok, YouTube, you're seeing a lot more males in the nursing field. You're seeing companies like Fig, who actually make scrubs. You know, in the beginning, they only made scrubs for females. So now they've transitioned. They're like, oh yeah, everybody's a nurse, a doctor. You know, it's kind of opened up. And I think a lot of that too was males are doctors, females are nurses. I think now, at least for my medical school, when I graduated, 50% of the medical students were female. So that is, as that changes in healthcare from a physician standpoint, I think it will trickle down to a nursing standpoint, and I think you'll start to see a lot more male nurses as well as female physicians throughout medicine. As far as the nursing shortage issue, there are a couple things. I'll address here first. So in Alabama, we get screwed by Blue Cross Blue Shield. At the end of the day, if I do a gallbladder in Atlanta versus a gallbladder here. Gallbladder in Atlanta, I get paid, we'll call it $1,000. In Atlanta, I get paid $1,000. Here, I'll get paid $1,100, okay? So as a physician, I say, okay, I'm getting paid better than the guys in Georgia, not a big deal. I'll just not complain about Blue Cross Blue Shield. But the problem is that the hospital in Georgia gets paid $6,000 for that gallbladder. In Alabama, we get paid $4,000 for that same gallbladder by Blue Cross Blue Shield. We get paid $4,500 for that same gallbladder by Medicare. So we sometimes get paid more for Medicare cases than we do Blue Cross Blue Shield. Now, what that does is that transitions to a situation where you have St. Vincent's. St. Vincent's, they got 20 hospitals. They can go to Blue Cross Blue Shield and say, hey, y'all need to give us that the Atlanta rate because we have this many people. They'll say, oh, we're not going to give you that, but we'll give you a little more. UAB, same thing. RMC comes, they're like, leave us alone. We don't want to talk to you. You're not enough to make a big difference. We don't really care. So we get stuck. You know, if we're 45 minutes from Tanner, 45 minutes from Birmingham, we're stuck in the middle. If I'm a nurse and I say you can start at $21 an hour in Anniston, you can go to Tanner and start at $28, $29. You can go to UAB and start at 27. So we're kind of squeezed in the middle and we don't have the ability to pay nurses well. Now, the irony of it is Jack State turns out and between Jack State and Gaston, we probably turn out about 150 to 200 nurses every 2 years. We are in a place that every hospital in America would love to be from a nursing standpoint because if we could pay what Birmingham pays or what Anniston pays, we could essentially fire half of our nurses every year, replace them, and we would still not be short. You know, I think Jack State maybe 2 years ago, they graduated about 108 nurses. Of that 108, only 8 started working at RMC. You know, so we have financial things that prevent us from being able to get nurses here, prevents us from getting nurses raises, prevents us from being able to take care of the people that take care of us. So when you...
How does an average citizen do anything about that?
Yes.
Like I said, if you know somebody...
Get our insurance somewhere else?
Well, you know, okay, well, hold on now. Now you wait a minute. I might have to step off screen for this one. So, you know, and yes, that's happening. You'll see United Healthcare come through. You'll see Cigna come through. So you'll see other insurance companies. But here's the problem. At the end of the day, insurance companies want one thing and one thing only. Money, not patients. They don't really care about the patients. It's a money thing. So if Blue Cross Blue Shield is paying the hospital $4,000, Medicare is paying $4,500, Cigna might come in and say, we'll pay y'all $4,800. So that's still better than Blue Cross Blue Shield, but that's not what they're paying Piedmont and Atlanta, which is $7,000. And again, we're still competing for the same nurses. Like I almost know more nurses that don't work at RMC in Anniston than I do nurses that work in RMC personally, just outside of work. Yes, ma'am.
Dr. Svensson asked if you would address eye coverage. Do we need to be wearing masks or goggles to protect our eyes or add another layer of protection?
Y'all gotta not ask good questions.
Do you mind repeating the question?
Oh yeah. So yeah, I'm sorry. So oh hey, Luce, what's up? I see you there. It's Bodenheimer. Hi. So the question was whether or not you should wear eye protection. The short answer is yes. The long answer is it depends on how you're looking at it. You know, if you're going from a 6 feet away from somebody, then eye protection may not be necessary, okay? Because all that 6 feet is based on the ability of you to sneeze or cough, and it travel at 60 to 100 miles an hour and be able to cover 6 feet. So if they're looking you directly in your eye, if someone coughs in your eye, yes, but you also have as soon as somebody coughs or air kind of does this, the first thing your eye does is close. So it's hard to say, is it absolutely necessary given if you're staying 6 feet? Now, I will tell you in the operating room, I wear eye protection. I don't do a case without eye protection because the other thing is HIV is usually transmitted through the eyes in the operating room than it is through needle sticks. So hepatitis C, same thing. So for us in the operating room, we always wear eye protection. And again, COVID is the same thing. Now, having said that, the full face shield that covers your eyes and your mouth is not a mask. That doesn't work. So if you see somebody out, stay away from them. That's not a good idea. What else?
What determines the amount of vaccine that's coming to this location?
Ooh, you're going to get me fired.
Do you need us to stop the camera?
I'll delete that one on mine. So that is a political question. You got to understand it. The way this was supposed to play out is CDC does everything, tells everybody where everything's going. You get what you got. We split it up by population density, and that's it. Okay. But the CDC kind of got removed from that process in the beginning. So the next step is how do you determine state by state? So there is a public health system that exists through your clinics, through the health department. So your state epidemiologist, and then you put a couple of political officials on that. The problem with that situation is, you would never ask your barber to take out your gallbladder. So asking a politician to help determine the vast complexities of how medicines are distributed, how they're given, how patients relate with physicians, and then come up with a number may not be the best way to do it. So that's why you've seen this kind of, okay, we got the vaccine, cool, what do we do with it? And really in medicine, that was the same thing we were seeing, not just being in medicine, but as people. People like, hey, well, we're going to get the vaccine. I'm like, hell, I don't know. They're like, well, Doc, what do you?
Whenever we get it.
They're like, don't we see you on the news talking about COVID? I'm like, yeah, man, but that's not our bag anymore. So what's happened now is because the CDC is back in play, because we now have physicians driving this like Fauci, as opposed to being pushed to the sideline, we're seeing a plan that is created. Now, you can't go back 6 months and say, okay, all these guys that created these, guys and gals that created these committees, we're not going to do that anymore. So you've kind of got this situation where you're kind of hybridizing a political plan versus a medical plan. So, and as time goes on, people are recognizing that, hey, the way that we wanted to do it is not working. Like in the news, they started talking about how 2 to 3% of the versus 5%, maybe I think it was 5% of the African American population was getting vaccinated. And it was, well, why is this not happening? So they started looking at the data and it was like, well, because y'all are distributing it wrong. You're talking about a population that already is below the poverty line. It always has issues from access anyway. You can't just, you either have to say, I have the vaccine, y'all come get it, or I have the vaccine, I'm bringing it to you. So initially it was, I'm coming, you just come get it, but we're not going to tell you where it is. And now it's more of a, we're going to you. So that's why you're hearing people talk about partnering with Walmart, partnering with local pharmacies. That's why you see us have this 1,000 a day for the next 5 days in Calhoun County through the public health department.
Anybody?
Sort of. So, man, stop asking all these good questions.
They still on like the tier?
Yeah, so we're still in 1B, so it's kind of like healthcare providers that haven't gotten their first responders, people that work in grocery stores, food handlers, teachers. So we're going through that staging thing. But that staging thing is contingent on us having enough doses. So realistically, if you said all the education workers in Calhoun County, y'all are 1B. That's cool and it sounds great, but if you have more education people than you do vaccines, that's a problem. So the staging is good, but it would be better if we had 10,000 doses we had to give out as opposed to 5,000 doses. So we have more people that need the vaccine than we have vaccines. So it's really right now a first come, first served basis. And what happened with us at RMC, we didn't anticipate that. So when we put out the phone number to call or the link to get your appointment, I think by 8:30 Monday, they were all locked down. You couldn't get it. So you have people that were 65 that, you said, hey, you got to get on your iPhone 12, hit this link, and then you're going to take it here, and then you got to fill this out, and then it's going to ask you for your password, or you can print it out. So by the time grandma got up to print it out, it was already full. There was no way to get it to her. So, again, we're suffering from the not having enough vaccine doses in the beginning to be able to supply, supply and demand, like any business. So, yes, sir.
Thank you for coming.
No problem.
I called today and RMC, and they said that they didn't have any more,
Correct.
and that Walmart was going to start dispensing it and go to walmart.com.
Yes.
I went to walmart.com, nobody in this area has any.
Right.
I said, well, surely they got in Atlanta, the 30303, nobody in Atlanta has any.
Right.
So when will Walmart have any?
So again, yeah, Benville, they got them all day. Again, you're asking the $1 million question. It's a matter of supply and demand. Pfizer's just committed to doubling their production to keep up with demand. So I think over the next 2 to maybe the next month or two, you will start to see everybody having them. But again, that's a state issue. If you go to South Carolina, their pharmacies already have them. So you literally can walk in, you register online with their app, which was messed up because the app crashed for a little bit, so there was an issue there. But you really could just log in on the app. As long as you logged in, call your pharmacy, and if they had some, they'd give it to you. So I think it's coming. I think that's just an Alabama Walmart issue. It's coming, but in the next 1 or 2 weeks. Because from a medical standpoint, in our minds, we want to have everybody vaccinated by the summer. By the time the kids come out, we want everybody vaccinated, at least the most people that we can, because that gives us the best shot of slowing everything down and being able to get back to some type of normal something. Yes, sir.
But your thought on the recommendation of some that we all should double mask?
Okay. So here's the thing. The double mask recommendation is based on the fact that there's not just one mask that everyone's wearing. You can net gaiter.
Specifications coming, are there not?
Well, there always been specifications from a healthcare standpoint. This mask that I wear is the same one I wear in the operating room. It is actually as effective as an N95 from a filtration standpoint. The only difference is that stuff comes in on the side here. Versus, I'll pick on somebody. So I'm sorry. So her mask is kind of what we call a level 1. So it's not one that I wear in the operating room because if blood goes through it, I can actually feel it on my lips. Versus for a respiratory tracking droplets, it's called about, I think the number was 88% effective. Versus this one's 92% effective versus is 95+% effective. So there's no one standard to say, hey, this mask works better than this one, because everything is a different situation. When I wear this one, it actually has an eye shield on it as well. I don't wear it out in public, but I'm also not closer than 6 feet to anybody. The double masking came out because a lot of people are wearing what I call them bootleg masks, but you'll see the ones that you could usually buy that are very thin and don't have 2 layers on them. They're thin enough to where they're not, like that one. Yeah, that's the bootleg one. So, or a neck gaiter. You'll see neck gaiters, or you'll see some that,
Like what you got on your panties.
right, pair of panties, right. So stuff like that
I didn't
works.
think you'd hear that.
Well, I'm sorry, my bad. But stuff like that is very thin. What I tell everybody is a good measure is light a candle, walk up to it and blow it out. If you can blow it out with your mask on, you probably need to double up. If you can't blow a candle out through it, you're probably good to go, and I wouldn't worry about it. Yeah, because that's another way you go, and if you can feel it, you're like, this one might not be the one I need to. I might need to wear another one. Look at everybody like, man, let me put this on and see.
You know how long it feels
Go home and light their
though
mask on
when
fire
you
accidentally.
sneeze, to sneeze in your mask?
Oh yeah, that's
Because
it.
then I'm like, I need to take it off. I'm just inhaling my own germs.
Right, and that's the thing is that works for me.
I know, but I
This
don't
works
want
for me because I got to go do a case after I finish here, so I'll throw this one away, put a new one on, and I'm gone. But if you don't have a supply of endless masks like I do, wearing something like this is probably not ideal because you need to change it out it probably should change it out at least every day. So that's the other thing with double masking is it came out because if you have an N95 and you're talking to or you're in a business place or something like that, someone coughs on your mask is not wearing one, you kind of don't want to pick that one up and change it off. So if you put a mask on top of it, I think that's what President Biden did, and that started it. He had 2 masks on. It was really not so much because he wanted better filtration than an N95. It was because he was trying to save his N95, so he had it on top, and that one he could throw away. He could, yes, sir.
So there's a question. Lucille had a question. It was, she said it seems, her understanding was that the vaccine now would eventually be more like an annual vaccine, that more like a flu vaccine. Is that the prognosis for the COVID-19 vaccine? That will also eventually be just an annual vaccine you get, or do we know?
I think that long term, it will probably be added to the flu vaccine that we normally get every year, and it will you won't even know it's there, and there will be a media blurb every once in a while, new variant, may or may not be, somebody's come out with a new one. But if you think about it, no one ever hears about what's in the flu vaccine. They don't even talk about it. You just go get it and you keep it moving. So I think this will transition into that at some point. Yes, ma'am.
So as far as kids are concerned, I know right now that we're not too concerned. We'd rather get all of the adults vaccinated.
Yes.
Do you think that they're going to in time
Yes.
for the kids to be vaccinated?
Yeah, so Pfizer and Moderna have both already entered trials for vaccinating kids.
Okay.
If I remember correctly, Moderna is for 16 and above. Pfizer is for 18 and above. But Pfizer went with 18 and above not because theirs wasn't good, it was because they were already entering that kid trial, so they wanted to just say 18 and above because that's a reasonable number, and then we'll find out. I think that they'll start giving that out. I think it probably, research-wise, I would say it'll be a year before we can get kids truly vaccinated. Is it safe? I'd say 90-something% of the 90, probably so. But if you don't, it's okay if grandma grows a third arm. If your kid does, it's a whole different issue. So they just kind of want to make sure.
Exactly.
Go ahead. I'm sorry. Yes, ma'am.
In terms of the vaccination to prevent pneumonia, does that help with the possible severity of COVID in older people? Do you think?
Okay. Yes. So the vaccine is not going to prevent you from getting COVID. It is going to decrease the severity of you when you have COVID and decrease the likelihood of you spreading it.
Of you what now?
Spreading it. So think of it as, if you get COVID, first thing you're going to do is start coughing. You've already exposed everybody in your household. Those people go to school, start coughing, they've exposed everybody else. But let's say if we gave you COVID and you weren't coughing, if you're washing your hands wearing a mask, you essentially wouldn't spread it anywhere. So you would So COVID would die within you and not spread throughout your family. You without a vaccine, if your O2 stat drops before 80%, you then come to the hospital. You've exposed everybody in the hospital to COVID. You've exposed all the nurses that are taking care of you to COVID, and you've you've occupied an ICU bed that would normally be taken up by somebody who has a stroke, high blood pressure, heart attack, cancer. Versus with the vaccine, your stats stay around 90. You do the protocol per the CDC, which is Pepcid, zinc, and vitamin C at home, and you never come to the hospital.
Let's go ask about, regarding our state representative, the legislators, should we make phone calls to them regarding trying to get more of the vaccine here in the community? And I ask this question because I heard this morning that there has gone missing 20 million vials of that vaccine is now supposed to be in the black market. And I certainly hope that behavior does not start around here. But people are desperate for this thing, especially from the standpoint of how can 20 million vials go unaccounted for?
Yeah,
It's just crazy what's happening, and you don't know what to do.
Right. So I've had people ask me that question a lot of times, and I tell them don't worry about it. I mean, I've never bought anything off the black market, and most people haven't. And plus, if some guy's telling you a vaccine shot out of the trunk of his car, I'm not sure I would even worry about it anyway. I'm like, I don't think it's that bad. And also remember that no one has to pay for this. It's free. So to tell someone you got $100 and I can get a vaccine now, remember it's not just one. You got to get two. So if you pay Pookie $100 the first time, you're going to have to pay him $1,000 the second time, and I don't think you can be able to find him 3 weeks after you had your first shot. So it's kind of so I think some of that is somebody heard that they disappeared, and it may have been they just fell off a truck. Somebody may have just, it's probably one of those supply chain issues. Somebody dropped it, and they're like, well, did they drop it, or did they throw it away? And then 3340's asking me, well, I heard that it got stolen, and it just kind of continues to escalate from that standpoint. Yeah, so don't get your vaccine out of somebody's trunk.
But we can call our representatives and say we need more.
So I'm going to go ahead and say, I'm going to answer this in two ways. From a member of the United States of America, I would say yes. Calling your representative is always a good thing. As a member of the RMC hospital board, don't waste your time. Yes, sir.
Real quick, why do some folks have a bad reaction after the second dose and another person might not even have it?
Perfect question. Okay, so what happens is the way your immune response works is the first dose you get, it's kind of like that first date. You don't know it doesn't know you, you're just kind of hanging out, talking to each other, everything's cool. Second date, that's when the action happens. Now, so what happens with the vaccine is the same way. But the difference is that some people have been exposed to COVID but haven't contracted it. Some people have had it and didn't know it. So a lot of times when you see people that get the very first vaccine and their fevers and chills and all that stuff at home, it's because they've been exposed to COVID in the past, didn't know it, they already got primed, so they're thinking it's their first date because they're getting that vaccine, and it's actually their second date. Does that make sense?
So the second one is a third date.
Correct. You're correct. And then what happens is the third date, they're just kind of like, oh, okay. We're like an old married couple. We're not doing anything but watching TV, so it doesn't really mess up that well. So
okay.
There you go.
I'm glad you brought that down to my level.
Oh,
Do you remember what it was like to have that?
First date, he's like.
Can I ask you a non-COVID question?
Absolutely.
Oh, please.
Bariatric bypasses.
Okay.
Bariatric, I guess it's a sleeve.
Yes, sir.
Were a tremendous fad, or whatever you want to call it.
Okay.
It was going on. In fact, one doctor here did over 3,000.
Yes, sir.
What's going on in that industry now?
Oh, man, we're rocking with the sleeves. Oh, I love a sleeve. I do sleeves as much. I saw a lady today. I saw 2 patients today. One I got to do in a couple weeks. So a sleeve is, I think a sleeve is the best bariatric operation we have on the market and have had on the market ever. The complication rate is low. It's the same as you getting your gallbladder out or your appendix out. The weight loss is anywhere from 75 to 150 to 200 pounds, depending on how large the patient is, as well as how much exercise and diet they're doing after they hit over that initial hump. I believe in sleeves. Everybody that comes in my office, if they're overweight or not, I'm like, consider it. You know, once you're looking at, you gain 10 years on the end of your life, whenever that comes, for a surgery that is outpatient, that we can do, and you're back to work in a week, you know, you lose.
Explain the difference real quick.
Okay, so with a bypass, what we actually do is take the top of your stomach, leave it in place, take the bottom of your stomach, move it to the side, and move intestine up. So what happens is you not only can't eat that much because you have a small pouch, but you also don't absorb all of your nutrients because we kind of skip a whole bunch of small intestine. That works great because you lose weight fast. The problem with that is that you lose weight fast. And you're also malnourished. So we're basically starving you and giving you enough food so you don't die. So that's why if you see patients with a bypass, they kind of look really sick, like that first couple of weeks after they've done. You're like, is she okay? Is she dying? Well, no, maybe not. And then they slowly get better over the next 2 years. That's because your body says, okay, I got this trick. You change this around, so I got to make this a little more efficient. So that's why after 2 years, you'll see patients start to gain weight back, and they'll start to look a little healthier because their body's figured out the trick. So the downside of a bypass surgery is if you look at 3 months, most of them lost 50% of their excess body weight. If you look at them in 3 years, they've gained 10% of that back. If you look at them 5 years, they're almost as big as they were before you did the surgery because their body's figured out the trick. Because you're doing all that rerouting, you have complications, hernias, stuff like that. Sleeve, there's no malabsorption component. So your mortality is already, or chance of dying is already lower. There is no rerouting of intestine, so your complication rate is lower. And it works by just saying, you can't eat that much anymore. And a lot of people, if you just say, hey, that's enough, you can't eat anymore, they lose weight. So that's why it's way safer. All right, no problem. Uh-oh, time man's coming up. Here we go. No problem. No, my pleasure.